So I'm Dr. Cuellar Silva. I'm a heart doctor, a cardiologist, but I specialize in the electrical system of the heart. So basically, we deal with the electrical activity, and whenever the heart goes out of rhythm, and we sometimes have to do some procedures and some workups and stuff that we would like to go over and try to keep it very simple and very informative for everyone. And we'll be taking questions at the end of the presentation. So basically, as the title says, we're going to talk about heart racing episodes. So this is directed for patients and people who will think that are having heart racing episodes. What does that mean? What could that be? So every time somebody has a heart racing episode, the possible diagnoses are this based on this list. It could be that you are having what we call sinus tachycardia, which is just the heart racing from the normal system. And in general, there's nothing to be done about it. It's part of the normal electrical activity. Although if somebody is having like very rapid heart rates from this sinus tachycardia, we'll need to look for secondary causes, like somebody may having a fever, somebody may having an infection, and the heart is responding to that. But other than that, the other possibilities are all abnormalities of the heart rhythm and the electrical activity. And these can be either SVT, stands for supraventricular tachycardia, or atrial fibrillation, which is what we're going to be mainly talking about today. Or also it could be atrial flutter, or it could be ventricular tachycardia. So all of these are abnormal, meaning that we need to treat it and you need to see a doctor for that. However, the ones that are most dangerous are these ones on the bottom, ventricular tachycardia. And that's the main reason we need to, when somebody is having some heart racing episodes, we need to definitely take a look at that and see if there is something abnormal that is dangerous, that will require a very urgent and a more invasive approach from the beginning. However, this is it is unlikely, and the most likely episodes are these ones, the three in the middle: supraventricular tachycardia, atrial fibrillation, or atrial flutter. So this is just to represent how the heart works. On the left-sided image, we can see what a normal heartbeat looks like. That the normal heartbeat starts from the sinus node, and it will send a signal going to the top left and the top right, and basically going around the top chambers of the heart. Then they connect right here in the center where it says AV node, and that's when the signal goes down below to the bottom chamber of the heart. So that is what maintains the normal rhythm of the heart. The top will beat first as a whole contraction, and then the bottom will follow that. And that way they will go in sync, 1 1 1 1. Now, atrial fibrillation, which is what really want to raise awareness today, is when the top chamber of the heart becomes very erratic, very disorganized rhythm. So all the points are going at the same time. So both of the top chambers of the heart will go out of sync. In other words, they just go extremely fast, and that can go to like at 200-300 beats per minute, but in different directions, that make the bottom also go fast, but the bottom is following that, trying to keep up with that, but it will never be able to because the bottom is not exactly the same and it will not follow the same speed, but it will go very irregular, meaning erratic. So if you compare here atrial fibrillation down the bottom on the bottom right, you can see how the spikes, the heartbeats go out of sync. It will one, and then a little bit of pause, then another one, and then longer, and then short, long, short. But if you look at the bottom left, the normal heartbeats, they go very in sync and it go at the same distance. It goes like beat, beat, beat. So that is the difference. So that is atrial fibrillation. Who has atrial fibrillation? Well, it's becoming more and more frequent and more prevalent across the countries. And if we look at the whole planet, we can see how the darkest zone of atrial fibrillation is in the US, in North America, in Canada. And in general, we believe and we know there's some genes associated to this, but also we know that a lot of stress and poor diets, as far as like new processed, ultra processed food, and they have a lot to do with that. Obesity has a lot to do with that. But over time, the prevalence has significantly increased in North America. In the US, this is the US, you can see how the current prevalence, we look at the year 2023, is about 8.9 up to like 9 million people with atrial fibrillation as of this was created a few years ago. But you can see how the prevalence is going up over time and is expected to hit a big mark in the next few years. So atrial fibrillation is definitely increasing and is going to go up. So what are the main symptoms? You know, who should be checked for, who should be concerned about it or seek for help? Well, the common symptoms are this. The number one is being reported is palpitation. So the heart feels like something is off in the chest. It feels like the heart is going out of rhythm. It feels like the heart is about to pump out of the chest. Those are called palpitations. But look at this, 50%, they only report fatigue. And we hear a lot of patients saying, you know, I just feel tired. I don't know what it is. And we ask her, do you feel something in your heart? They say, no, I just feel tired. And basically tired for the last few months, for the last few weeks, but it's just tiredness. Also, some people say, well, I just feel short of breath. And that's also very common. Some people say there's something is not right, some having some malaise, some dizziness, anxiety, chest pains, and other less common. But these are the symptoms that could represent atrial fibrillation. Now, if you have atrial fibrillation, what are you at risk for? And that's very important. Some people say, well, somebody diagnosed me with atrial fibrillation, but I feel okay, I can live with it. Well, you can live with it, that's correct. However, you need to be aware of the potential risk down the road. The main problem when somebody has atrial fibrillation is the risk for a stroke. So the risk for stroke definitely increases and it goes up over time whenever somebody has atrial fibrillation. That's the main thing. But also, if you look down here, there are other risk factors here that would increase with atrial fibrillation. The second one is congestive heart failure. So the heart can become weak over time. It also increase with hypertension And there are other risks like age, diabetes, and the stroke. But the main thing to remember is if somebody has atrial fibrillation, will have significantly increased risk for stroke. In the past, I guess we didn't have enough data, and I'm talking about in the 80s, early 90s, that somebody with atrial fibrillation could just take aspirin and then take some blood thinners, over time develop to prevent strokes. But over the last 15 years, we came to a conclusion that many more people will benefit from being on blood thinners to prevent strokes, because we found out that the risk for stroke is higher and higher every time somebody has atrial fibrillation. So nowadays, the main intervention, the main treatment that you need to seek for and look for whenever you are diagnosed with atrial fibrillation is to prevent strokes with blood thinners. And that's why many people say, well, I have palpitations, I have these symptoms, but I just don't want to go to the doctor. Well, it's okay if you don't want to do particular treatments for atrial fibrillation and stuff initially, but the main thing that you need to have a clear diagnosis is that if you do have atrial fibrillation, you will need to be on blood thinners. And that's when you need to see the doctor and have a good conversation about the blood thinners. So how do we diagnose atrial fibrillation? So the main diagnosis is done by an EKG. I'm sure many people have had an electrocardiogram, which is an EKG that is done at the doctor's office. And this is what you see here. Again, you see how the beats are irregular. They go one and then a long pause before the other one and then a short. So go long, slow, fast. That's out of rhythm. So that's how you make the diagnosis of atrial fibrillation. But many times, the atrial fibrillation comes and goes. Especially at the beginning, you can have episodes of palpitations and stuff, and that can be atrial fibrillation. But then the heart goes back to normal rhythm. And whenever you go see the doctor, you are in normal rhythm. So it's hard to diagnose sometimes. And that's why we do the Holter monitor, which is like wearing a EKG, some stickers. Is nothing too hard, but you can wear, and we put some of those in the office. You go home with it. Sometimes we do it for 24 hours, but usually we do it for a week or 2 weeks in order to tell whether you are in and out of atrial fibrillation. Now, nowadays it's important than the wearables, like the iWatch and those watches that can monitor your heart rate and stuff. They actually work very well. Not perfect, they're not the most accurate, but in general, it's a very good way to do some sort of a screening first approach. So if you have some of those wearables, go ahead and pay attention to it. If you may get some alarms, you may get some strips, you may get some signs that you may be in abnormal rhythm. And if that's the case, then just make sure you go to the doctor, and at that time we either confirm or disprove and rule out that diagnosis, but always pay attention to those wearables. We have diagnosed sometimes very, very clear strips from those wearables whenever somebody comes with those and they show it to us, and we can see pretty fairly good quality strips. And so always pay attention to that. So once you have atrial fibrillation, we know atrial fibrillation is just not a good thing to have because increases the risk for stroke, increases the chances for weakness in your heart. So what potential treatments we have? Well, number one is medicines. There are some medicines that are very specific for atrial fibrillation, and sometimes they work, sometimes they don't work. But I'm here to say that it is we need to always analyze specific cases depending on the comorbidities and other medical problems. We can use certain medicines. There are some medicines we cannot use on certain people. So you have to have a very good base of knowledge in order to prescribe these medicines. So that's why it's very good for you, if you have atrial fibrillation, to be diagnosed by a specialist and always be treated by a specialist about this. What the medicines are always a balance on side effects. There are some potential side effects down the road, some potential benefits, and that's a big discussion with your heart doctor once you are starting a treatment. The second step on the treatment is called cardioversion. Cardioversion is, as you can see on the picture, there is a similar to whenever somebody gets like a shock from the ambulance, we can give you anesthesia for about 5 seconds and deliver a single shock, and that can reset the heart in normal rhythm. So that sometimes is necessary. Is not the end goal or end goal of treatment, because once you do the shock, it is the most likely the atrial fibrillation will come back, but that sometimes is necessary in order to start some medicines and other things. But the real treatment is cardiac ablation. That is the treatment, the procedure that we do. And I'll show you some more pictures about this. But this picture represents the top left side of the heart, which is where atrial fibrillation is coming from in general. We advance a wire that is specifically designed for being inside the heart, and we cauterize around those veins that are connected into the heart. So this procedure, we do it under anesthesia, takes about an hour to do. In general, patient goes home. They go home in the afternoon, they go home the same day. Recovery is in general very, very light. Just kind of take it easy and be cautious for about 2 or 3 days. We go from the groin, so we don't do a full incision, a big cut, or major surgeries. It's all from the groin. So the ablation is the only potential treatment for atrial fibrillation, because if you think about it, if you take medicines, and if the medicine is working, it's fine, but you are controlling it. You are not treating it. In other words, whenever you stop the medicines, the atrial fibrillation will come back. Whereas the ablation, if you're free of atrial fibrillation, then that's what's going to give you the best chance to not going back into atrial fibrillation. Now, Watchman is a very important step in the treatment for some patients who cannot take blood thinners for a long time. So in order to prevent strokes, we can do the Watchman procedure, and that way we will preventing the strokes without having to take the blood thinners. So these two procedures are the main treatment for atrial fibrillation nowadays. So this is just to go over the list of potential medicines we can use, the beta blocker, the Multac, other medicines that we can use, that the more effective they are, the more potent they are, the more side effects they have down the road. And also we have the blood thinners. We talk about preventing strokes, and these are the list of the blood thinners that you and many people are familiar with. So just to talk about the Watchman. So again, whenever somebody is having issues with the blood thinners, having some sort of bleeding, then we can do the Watchman, which is again from the groin, similar to the ablation. We go from the groin and we put a small plug inside the heart, and this plug will keep the blood clots to form. So if somebody's having atrial fibrillation and having a stroke, that stroke is coming from blood clots. So by putting this plug, the heart will not form blood clots, so you will not have a risk for a stroke anymore. And it's a procedure, we do it under anesthesia. Usually patients go home the same day. Again, we do it from the groin, and this is called Watchman procedure. And these are the steps for the Watchman procedure. Now, the ablation, again, we create a 3D map of the heart. And as you can see, this little person here, that's kind of a representation of the patient, that we're looking at the top chamber of the heart from the back. And we create this with a special wire that is designed to create this sort of 3D maps of the heart. And then we cauterize in some certain areas. We do a small cauterization points, and in order to prevent these extra beats to form, in order to prevent the heart to go out of sync. And that's how the cardiac ablation works. And the technology has gotten a lot better. The ablations that we do today are totally different than the ablations we did 7, 8 years ago, because we have high density mapping systems, and the technology is very, very advanced. So for an ablation procedure, the step one is we get like a venous through the groin, and then we advance that wire into the heart. We use some sort of like X-rays and some other systems to tell we are inside the heart, with an ultrasound as well. Then we create a 3D map, and then we cauterize the areas that we mentioned, and patients go home in general the same day. And another thing is atrial flutter. So atrial flutter is similar to atrial fibrillation. They're kind of cousins. Atrial flutter can increase the risk for a stroke as well, and it should be treated the same way. We also do ablations for this, but I wanted to show you, once we create a 3D map of the heart, this is how it looks like. And that you can see all the signals in red are going around one particular area. We create that. This is a real person. This is a real case. And by cauterizing and burning in a few spots here, the flutter would terminate into normal rhythm. And this is how the atrial flutter looks like whenever we create a map of the heart with this technology. I wanted to show you a representation of this. And with this, I just want to end the presentation for today. Again, important to, whenever somebody has some sort of heart racing episodes, to not ignore it. Always try to find some help. If they don't happen too frequent, if you're not too worried about it, you can have some sort of wearables. You can have like an Apple iWatch. You can have any brand of a watch that will check for your rhythm. And if you get concerned and the episodes continue to increase, make sure you look for medical attention. We'll be happy to see you. This is our office. This is 3 of us electrophysiologists working in our group. We'll be happy to see you and guide you and give and discuss the best potential treatments when necessary.